Yeah. So once again, good evening. So today we have our speaker, Dr. Khalil Khan. He has done his MBBS from Mimsar Burla. Afterwards, he did his MD in pediatrics. Then followed from MKCG Behrampur. Afterwards, he did IDPCCM and IAP ISSCM. He is national faculty IAP and ALS and BP ICCs. Currently, he is heading our pediatric intensive unit at Ankura Hospital, Hyderabad. He is a very well-known pediatrician in Hyderabad and well-known, you can say, a trainer also for other fellow. So, sir, welcome to the station.
Yeah, thank you, Pooja. Thank you for that kind introduction. So, shall we start the session?
Yes, sir.
Yeah. Good evening, dear friends. Today we will be discussing about the recent advances in pediatric critical care. As we all know, pediatric critical is a challenging specialty, and the updates in pediatric critical care were also quite important, and we need to keep ourselves updated about the changes that is happening in pediatric critical care. So, I will be presenting these advances with the following outline. So we'll be discussing about fluids, then we'll be discussing about the important respiratory topic like the ARDS, followed by infections, cardiac critical care, a bit of COVID-19 related multisystem inflammatory syndrome in children. We'll be discussing about the transfusion guidelines in pediatric population, particularly in the ICU cases. We'll be briefly discussing about the metabolic problem like the DKA, and followed by it, the abdominal and neurologic issues with regard to the pediatric traumatic brain injury. So coming to the first topic, the fluids. Fluid administration is the first intervention performed when we encounter a child with circulatory failure. Crystalloids are chosen globally as the initial fluid of resuscitation. However, the composition of different crystalloids is not same. If you see this table where the composition of the plasma has been compared with other crystalloids like normal saline, ringer lactate, as well as plasma light or normosol, you can see the plasma has a sodium concentration of 140, a chloride of around 100, and a osmolarity of 290. So that is what our plasma is made up of. If you see the concentration of other crystalloids like sodium chloride, it has a high sodium compared to our plasma. So too the chloride concentration. If you see ringer lactate, it has almost similar concentration of sodium as well as chloride with addition of other electrolytes as well as buffers. Coming to the last but the most important one, the plasma light. So this is the one which is most identical with that of our plasma. So it has equal sodium concentration as that of our plasma, so as the chloride concentration. Along with that, it has other cations and anions in form of buffers, and its osmolality is close to that of the plasma. Now, what is balanced crystalloids? This is a debate and logical reasoning. So let us know what are balanced fluids. By means of balancing, what are we talking about? So balanced fluids are the fluids whose composition is similar to that of the plasma. By means of balancing, what we mean is we want to balance the tonicity, the electrolyte concentration, as well as the pH. So with this background, we can see that the composition of our plasma is almost comparable with that of the balanced salt solutions. Now coming to the normal saline, which is 0.9% sodium chloride. Though it is called as normal, there is nothing normal about it. So when you see, neither it is isotonic, in fact, it is a bit hypertonic. And when you compare the concentration of sodium and chloride, sodium is 10% higher than that of the plasma, and chloride is almost 50% higher. So in no way it is matching with that of the plasma. Thereby, though it is the most commonly used fluid in pediatric critical care for resuscitative purpose because it's easily available, it's cheap, and it has been used over decades. But the trend is changing because it has got its own set of maladies. It can cause hyperchloremic metabolic acidosis because of its high chloride concentration. And the root cause of all the problems with normal saline is its high chloride concentration. So when normal saline is infused in large volume during active resuscitation, it may lead to metabolic acidosis, though it won't cause severe metabolic acidosis, but it can be mild to moderate with a base deficit of around -10. But that itself can cause problems, particularly related to kidney. It can cause acute kidney injury by its effect on the afferent vessels of the kidney. It can cause bleeding and coagulopathy. And as metabolic acidosis leads to shift of potassium from the cells to the plasma, it can lead to hyperkalemia. So, are we doing the right thing by giving normal saline for resuscitating the kids? Again, it's a debate. Now, there are two large randomized controlled trials comparing the balanced salt solution, which is plasmalite or normosol, with normal saline. These two studies, one is the SMART, that is isotonic solutions and major adverse renal events trial, as well as the salted, which is saline against lactate in emergency department. Both these RCTs did not find any difference in primary outcome, but certainly it showed less risk of renal injury. The Surviving Sepsis Campaign International Guidelines of 2020 suggest balanced buffered crystalloids to be preferred over normal saline for resuscitation of children with septic shock or other sepsis-associated organ dysfunction. Is the evidence getting stronger for balanced salt solution? Certainly, but we need more robust evidence to recommend using balanced salt solution in all patients in all situations. Now, coming to the most important respiratory problem which we encounter in pediatric critical care, ARDS. Since the first description of ARDS by Oshbo in 1967, it has been recognized as one of the most important respiratory problems in kids. But the definitions which have been given for ARDS are mostly adult oriented, and it has been recognized since long the need to be a pediatric centric definition of ARDS. Now, coming to the definitions which are mostly been described, the Berlin criteria as well as the Palissy definition of ARDS. The difference between these two, as we all know that ARDS or acute respiratory distress syndrome, the time of onset should be acute, that is within 7 days of a known clinical insult. The origin of edema should be of respiratory cause, which is not fully explained by cardiac failure or fluid overload, and chest imaging, which should show infiltrates consistent with acute pulmonary parenchymal disease, and the oxygenation criteria. This is where the difference between the Berlin criteria and the Palissy definition. Whereas in Berlin criteria, the PF ratio is taken to classify the severity of ARDS into mild, moderate, and severe. Like 200 to 300 is mild, 200 to 200 is moderate, and less than 100 is severe, provided there should be a minimum PEEP of 5 centimeter of water. So that's how it is defined. With a PEEP of 5 centimeter of water, the PF ratio decides the severity of the ARDS as per the Berlin definition. Now, the Palissy definition of ARDS takes into account the oxygenation index. The oxygenation index is your less than 4 to less than 8 is mild, 8 to 16 is moderate, and more than 16 is severe. And as well as the oxygen saturation index. So the difference between the PF ratio and the saturation FiO2 ratio. So here you need not measure the PaO2. So for measuring the arterial oxygen tension, you need to have an arterial line, which is difficult in pediatric population in most of the centers except for the level 3 ICUs where it is routinely placed. But for centers which caters for sick kids and where there is no facility or expertise to place a arterial line, they can do it with the SF ratio. The SF ratio is your saturation, which can be easily monitored with a pulse oximeter, and the FiO2. FiO2 is the fraction of oxygen which you are giving. And similarly, the OSI, that is the oxygen saturation index. Oxygen saturation index is your mean airway pressure multiplied by FiO2 divided by your saturation into 100. So again, 5 to 7.5 is mild, 7.5 to 12.3 is moderate, and more than 12.3 is severe ARDS. So the basic difference between the Berlin and the Palissy definition is it is more pediatric centric. It obviates the need for measuring the PaO2. So this we will be seeing in the next slide. The limitation, as I said, the Berlin definition is more adult focused, and pediatric risk factors are not considered while preparing the criteria for Berlin definition. The need for measurement of PO2, as I said, an invasive measurement where most of the time it may not be possible in level 2 centers, and the PF ratio, which is influenced by ventilator pressures. So these are the disadvantages of Berlin, which are overcome by this Palissy definition. It obviates the need for measurement of PaO2 because you can measure the saturation is to FiO2, as well as the ease of calculation of oxygen saturation index. Now, the management of ARDS, certain things have high level of proof with regard to the recommendations. These are the tidal volume, the plateau pressure, PEEP, and proning. We all know we have moved away from the time of ventilating children with high tidal volumes of 10 to 12 ml per kgs, because such high tidal volume has led to complications, and it has led to what we call it as VILI, which is ventilator-induced lung injury. Ventilator-induced lung injury can be in the form of volutrauma, atelectotrauma, barotrauma, or biotrauma, and all these are quite dangerous when it comes to the outcome in managing of these children with severe ARDS. So the current trend, or the trend which has been now followed, is the low tidal volume, which is 4 to 8 ml per kg idle body weight. Plateau pressure, again, what is plateau pressure? Plateau pressure is the distending alveolar distending pressure. So when you have a child who is sedated and paralyzed in a controlled mode, we do an inspiratory pause. Your ventilator is provided with a button where you can just push it and wait for 2 to 3 seconds, which will measure the plateau pressure. So in ventilating children, your plateau pressure should not exceed 28 to 30. In cases of severe, it can go a bit towards the higher range, but ideally your aim is to limit the plateau pressure to less than 28. The third important aspect, which has a high level of proof in managing children with ARDS, is the PEEP. We all know PEEP keeps the alveoli in a partially open state. The repeated closing and opening of the alveoli will lead to atelectotrauma. So it has been proved beyond doubt that PEEP helps and The level of PEEP which the child needs depends on the severity of the ARDS. Any PEEP level more than 12 is regarded as a high PEEP, and in cases of severe ARDS where the PF ratio is less than 100, you may need high PEEP to keep the alveoli open so that the chances of villi is minimized. Pruning. So again, in severe ARDS, it has been seen that early pruning has found to have definite benefit, but you need to have a dedicated team trained in managing children, and the whole art of pruning has to be learned. Again, pruning is helps in recruitment as well as changing the type of lung physiology and pathology. So if you are aware of the west zones of the lungs, the ideal, the like west zone 1, 2, and 3. So ideally the lungs needs to be in a zone 2. So by pruning, you change this zone more in favorable of zone 2, thereby it improves your oxygenation. Again, while pruning, it has to be, there should be a prolonged, it should not be like you prune for 1 hour, then again you made the child supine. So pruning, it should be more than 12 hours, and it should be done for a prolonged period as the situation demands. Now, coming to the early management of ARDS, as we have already discussed the definition. So there is a role of non-invasive mechanical ventilation in children who have mild ARDS. So where you can try either the CPAP or the BiPAP with an FiO2 requirement of more than 40%, so as to target a saturation in the range of 88 to 97%. So this can be given either by oxygen mask or via nasal cannula or a high flow nasal cannula. So the target should be to maintain a saturation in the range of 88 to 97%, and accordingly you have to titrate your FiO2. Coming to the more moderate and severe varieties, you need to have the child ventilated. Ideally, you should use a cuffed endotracheal tube, which should be largest size for the age of the child, so as to prevent a leak, except for children who are on high frequency oscillatory ventilation, where you need to allow a bit of leak so as to help in washing out of the carbon dioxide. Now, the initiation of invasive mechanical ventilation. So in the initial period, where you need to overcome the asynchrony and lot of other things, you need to sedate, and if needed, use neuromuscular blocking agent. So as I said, low tidal volume strategy, 4 to 6 ml per kg of predicted body weight in absence of severe metabolic acidosis. Then as the severity increases, so you need to optimize your ventilatory settings. You need to titrate your PEEP, and if you have a very bad or stiff lung, then you need to and there is hypercapnia with low oxygenation, so you need to titrate your PEEP either by PEEP titration or what we call it as recruitment maneuvers. And again, when you talk about recruitment maneuvers, incremental or decremental PEEP is ideal in these scenarios rather than applying sustained inflation pressures. So in the more severe forms, where you have used your maximum ventilatory settings and the child is still having poor oxygenation, then there is a definite role for ECMO. When you breach in the waiting time, you want to bridge the child to ECMO, you can just try some of the therapies in the form of inhaled nitric oxide, which may give you some time so that you can shift the child to a higher level of care, where no veno-venous ECMO has been tried with success. So usually veno-venous ECMO in case of refractory hypoxemia or when protective ventilation cannot be applied. So to be discussed with experienced centers which are well equipped to handle these type of children. Now coming to the evolving concept in ARDS, so there is an important concept of driving pressure. So driving pressure is nothing but the difference between the plateau pressure and the PEEP. So the difference, as the plateau pressure increases, so your driving pressure increases. A high driving pressure is a bad sign and indicates that your lung is quite stiff. Again, when you increase the PEEP, your drive, as I told you, the driving pressure is nothing but difference between plateau pressure and PEEP. So as the plateau pressure increases, your driving pressure will also increase. Your target should be to keep the driving pressure as low as possible. Ideally, it should be below 15 to 16. So if your plateau pressure is high, your driving pressure is high. If your PEEP is high, your driving pressure will be low. And when you combine the PEEP with tidal volume, then your driving pressure decreases. So the target is to keep the driving pressure as low as possible. It's an evolving concept. It has it's one of the most important topic discussed in adult critical care, but sooner or later we would be seeing with more robust on studies, maybe the concept of driving pressure will be discussed in pediatrics as well. So as I said, your target should be to limit the plateau pressure to less than 30. Similarly, the driving pressure should be limited to less than 15 to at best 18. Now, coming to, as we have discussed, the types of ARDS depending on the severity as mild, moderate, and severe. There are new phenotypes of ARDS. Like the hyperinflammatory type, you have a predominance of the inflammatory markers, and the hypoinflammatory type, where you have paucity of these inflammatory markers. Now, what is the importance of these two phenotypes? There is certainly an importance with regard to the management of these two different types, whereas the hyperinflammatory type needs high PEEP and conservative fluid, or the hypoinflammatory type might be harmed by such intervention. So you may need to keep a low PEEP, and you need to have a liberal fluid policy for hypoinflammatory type. So again, these are the evolving concepts in ARDS. So let's see what's going to be the management in the future when we take into consideration the different phenotypes. But as of now, so two phenotypes with two different lines of management. Now coming to sepsis and septic shock. Now sepsis is a highly heterogeneous and multifaceted syndrome. Due to concerns with the non-specific nature of SIRS, new definition of sepsis, that is sepsis 3, was introduced. Now, according to this sepsis 3 definition, sepsis is defined as a life-threatening organ dysfunction which is caused by dysregulated host response to an infection. So you get an infection, your immune system mounts a response against that infection, and when that response gets dysregulated, you'll end up in complications. So it's all about like your body immunity, how best it handles your infection. So it can cause your own body damage when it is dysregulated. Now coming to the definition of septic shock. Sepsis with circulatory or metabolic dysfunction is regarded as septic shock. Circulatory dysfunction means you will have clinical signs of septic shock. I mean clinical signs of shock. Either it is compensated, where you get tachycardia, tachypnea, prolonged cap refill time, your extremities may become cold. You may have either low volume pulse or bounding pulses. So depending on our traditional teaching, we used to classify it as cold shock when the extremities appear cold, when the pulses are feeble, when the cap refill time is prolonged, or warm shock when the extremities are warm, cap refill time is flash, and pulses are bounding. But this clinical differentiation of shock into cold and warm can be erroneous. It has been seen that most of the time what we think as a cold shock may not be cold. So there are specific ways to determine it. So it's usually beyond the scope of most of the level 2 centers, where centers which are equipped with monitoring tools, where you can monitor things like your cardiac index, like your cardiac output divided by your body surface area, or your systemic vascular resistance index. There you can differentiate exactly what is cold, what is warm. So the manual assessment may be wrong at times, but having said that, for centers where only clinical judgment is important, we can go by our clinical criteria. Because when we come to management wise, so more or less, yeah, even if you are on the side of judgment between cold and warm, but management wise, most of them you end up using inotropes, which helps either way. Metabolic, by metabolic dysfunction we mean, so the decreased oxygen demand, I mean this the decreased oxygen delivery and consumption will lead to metabolic dysfunction. And one of the most important surrogate marker of metabolic dysfunction is your lactate. So when your lactate increases beyond 2 millimole per liter, you call it as septic shock. And coming to the hypotensive shock, where it's quite a late finding, when you have lost the golden hour of management, and once it becomes hypotensive, and there will be a rapid downhill course. Now, with regard to this sepsis 3 definition, the pediatric SOFA or sequential organ failure assessment. So, to know the severity of sepsis or organ dysfunction, so the new definition and SOFA scores predict the mortality better. Now, the applicability to the pediatric population is troublesome, as SOFA initially did not have a pediatric specific score. But after the pediatric SOFA has been developed, so there has been a good correlation between the severity of sepsis and high SOFA score with increasing mortality. So the sequential organ failure assessment uses common clinical and lab tests. It assesses the major systems of the body like your CNS, CVS, respiratory, hepatic, renal, and coagulation function. So the specific highlights of the pediatric SOFA is it takes into account the age-adjusted cutoff for the cardiovascular and renal parameters, which were not there before. And it also takes into account the SpO2 FiO2 ratio as a non-invasive surrogate of acute lung injury. So higher the score, bad is the prognosis. You can see from this table the variables which are taken to get the SOFA score, and the range is from 0 to 5. So a higher score, increasing severity and bad prognosis. Now coming to the algorithm for resuscitation of children. Again, this is from the Surviving Sepsis campaign of 2020. So we all know that time is important when managing critically ill children. When you have systemic screening for sepsis in children and you have identified sepsis, then you categorized it into septic shock on your clinical judgment, then things has to go fast. So you have to obtain an IV access. If you fail to get an IV access, establish an intraosseous access. Don't waste time in securing an IV access. At times in children who are in shock, it's difficult. So please do have an intraosseous needle so that you can just secure a vascular access. If time permits, please do collect blood for culture, give an empiric dose of broad spectrum antibiotic, measure lactate, administer fluid boluses if shock is present. Start vasoactive agents if shock persists. Now, the importance of fluid and vasoactive agents, we all know, makes difference in the outcome of these children. If you see this, the child needs respiratory support, assess for the respiratory status, and do continuous assessment. You titrate your fluid and vasoactive therapies, and if there is a clear-cut source of infection, you have to address and control the source. And if the facility permits, you have to go for advanced hemodynamic monitoring. So again, regarding the fluid boluses, we will be seeing in the next slide the how what is the optimal choice of fluid, how fast it should be given, and what is the continuous assessment you need to follow when you manage these children. It's not like you just advise fluid and you go away from the scene. So you have to stand near the child and you have to assess for the response to fluid. If you don't assess the response, then you may end up either under treating or over treating, and both of which can prove costly, and you may end up losing the child. So there are other important aspects you need to follow, like point of care testing for hypoglycemia. Most of these children, because of the poor intake and because of infection, they may have hypoglycemia. You have to do a bedside GRBS and correct it, and at the same time continuous monitoring is very important. Now, coming to the fluid and vasoactive management of algorithm for children, this is a change from the existing guidelines. Now, this has been divided into healthcare systems with intensive care and healthcare systems without intensive care. So, most of us are fortunate that we are working in tertiary level centers, but some of our friends, they work in challenging conditions and they have to handle a very huge caseload. I mean, in those scenarios, these guidelines give them the algorithm what they need to do. Now, let me start with the healthcare setup without an intensive care. When you have a child with septic shock, you have diagnosed it by means of your clinical parameters, and this child is having abnormal perfusion. By abnormal perfusion, I mean like low volume pulses or bounding pulses, prolonged or flash cap refill time, cold extremities or warm extremities, and your tachycardia, but without hypotension. So in these scenarios, there is no need to give fluid boluses. So here what we can do is you can just start on maintenance fluid, monitor hemodynamics. These children can improve at the same time. There is a high chance that they may deteriorate. So again, I'm re-emphasizing again and again the need for close hemodynamic monitoring. Now consider vasoactive inotropic support if available. Here again, if you feel that you need to start inotropes, you can start. The old saying was like you can't give adrenaline, noradrenaline through peripheral line, but the current guideline says you can start your vasoactive agents or inotropes even through peripheral line, even after the first fluid bolus. Again, the most important thing while giving fluid bolus, as I said, I'm again and again saying that it has to be closely monitored. What things needs to be monitored? You monitor the heart rate. With fluids, the heart rate should come down. And even though you're not giving fluid boluses in children without hypertension, you need even the maintenance fluid can cause decompensation. So when you have a child with abnormal perfusion and with hypotension, so these are the children who are at high risk of rapid downhill course. If signs of fluid overload are absent, by signs of fluid overload, you mean you have to look for the liver span. You have to auscultate the lung bases for crepitations. So if you have a child with no signs of fluid overload, administer fluid bolus 10 to 20 ml per kg. Again, it can be 10 and 20. So again, what is the duration? So most of us have the habit that when you have hypertension, we tend to push very rapidly. So again, the push thing has got to be abundant. So you can give if the child is hypotensive without a facility for monitoring, if you have signs of fluid overload, you have to be very careful and you have to be very slow in giving fluid boluses. Now, if you assess the hemodynamics after the fluid bolus, again, you can assess whether the child needs a second bolus until hypotension resolves or signs of fluid overload develops. So as I said, what should be the duration over which you should give this fluid boluses? These fluid boluses should be given over 15 to 20 minutes. So the target is you give up to, in resource limited settings, you give up to 40 ml per kg in the first hour. So when you give 40 ml per kg in the first hour, so you can give slowly. It can be 15 to 30 minutes. If you're giving 20 ml per kg, then give, depending on the clinical scenario, you can give over 15 minutes, but don't keep on pushing. So always again assess for signs of fluid overload. Consider epinephrine or norepinephrine if hypotension persists after 40 ml per kg, or even sooner if the child develops signs of fluid overload. Again, there is a change from the normal use of inotropes. So dopamine is now out of question. But in resource poor settings, if you don't get epinephrine or norepinephrine, then you can start with dopamine in a dose of 10 mics per kg per minute. Why dopamine is out? There's a big, literature behind it. Now, coming to children with abnormal perfusion with or without hypotension in a unit with well equipped intensive care facilities. So give 20 to 20 ml per kg. Again, the duration can range from 10 to 15 minutes. Repeat assessment of hemodynamic response to fluid and consider further fluid challenges till shock resolves or signs of fluid overload develops. Assess cardiac function. Consider epinephrine if there is myocardial dysfunction, or epinephrine along with norepinephrine if shock persists. Beyond, if shock persists even after giving 40 to 60 mils per kg of fluid, or sooner if signs of fluid overload develops. See, all the children may not be fluid responsive. So again, it has been seen that 50% of the children with septic shock may not respond to fluid. It's all to do with your where your heart is operating. You have a Starling curve. So when the heart is, when you see the Starling curve, when it is operating on the steep part, they are fluid responsive, and when the heart is operating on the flat part of the Starling curve, then usually they don't, and they decompensate with fluid, developing signs of fluid overload. Now, at the end of this fluid bolus and inotropes, if shock resolved, perfusion improved, then consider maintenance fluid, monitor for signs and symptoms of recurrent shock. So again, the importance of monitoring. So with regard to hypotension in healthcare systems without intensive care, hypotension is defined by age norms. For less than 1 year, less than 50. For 1 to 5 years, less than 60. For above 5 years, less than 70. So 50, 60, 70 is the cutoff for less than 1 year, 1 to 5 year, and more than 5-year children. Now, as per the WHO criteria, cold extremities, prolonged capillary refill time, and weak or fast pulse again are signs of hypotension. And when you go by WHO criteria, they advise giving fluid bolus still slower over a prolonged period. Now we all are now in the middle of a very dangerous pandemic. So no country has been left unscathed by the corona pandemic. So the corona pandemic has caused some of the most alarming problem in children. So as we all know that vast majority of children with COVID-19 are asymptomatic, but very few of them can develop a rare complication in form of this multisystem inflammatory syndrome. Now, the criteria to define this multisystem inflammatory syndrome is fever with an epidemiologic link to SARS coronavirus 2 and at least 2 suggestive clinical features, either rash, presence of GI symptoms, edema of hands and feet, oral mucosal changes, conjunctivitis, lymphadenopathy, or neurologic symptoms. So we all know that this multisystem inflammatory syndrome has clinical features akin to Kawasaki disease. So if you find any of these symptoms like fever along with an epidemiologic link to SARS coronavirus 2 and these other clinical features, so if you have these symptoms, then does the child look sick? Is the child is in shock? Then if you see that the child is looking sick, having signs of shock, then you have to complete the full diagnostic evaluation for this syndrome. What I mean by full diagnostic evaluation is, so you have to go for this tier 1 and tier 2 evaluation. In tier 1 you do this routine test like your CBP, your ESR, CRP, and your SARS coronavirus 2 RT-PCR and serologies. At the same time, you go for the complete evaluation like pro-BNP, like brain natriuretic peptide, TROP-T, ProCal, ferritin, prothrombin, then partial thromboplastin time, D-dimer, fibrinogen, LDH, the cytokine panel, particularly the interleukin 6 and interleukin 2 are triglycerides. So depending on these, the management of this multisystem inflammatory syndrome is discussed. Now, when you have none of these features, the child can develop in due course. So you have to keep monitoring for or to keep a watch for these symptoms. So now coming to the management of children with this syndrome. So as I said, some of these children can have very mild disease if proper follow-up can be advised or they can follow up regularly, you can advise home-based treatment. Now the ones with the complete or the severe forms, they need to be admitted and they need to be monitored in an ICU, and the treatment modality could be your immunomodulatory therapies like your IVIG, glucocorticoid, and in children with severe signs of hyperinflammation, you can even use your cytokine inhibitors like your anakinra and your tocilizumab. Similarly, these children can have, I mean, problems with coagulation. So where you need to start on antiplatelet drugs like low dose aspirin, or even when the ejection fraction is low. When you do a 2D echo and when you see the ejection fraction is low, these children may have a high risk of having intramural clots in the heart, where you need to put them on enoxaparin. So when this fulfills the criteria for Kawasaki disease, again, as I said, IVIG, aspirin, and consider low molecular weight heparin. So most of these children and most of the centers have come across in this last 1 month across, with children who are manifesting with these type of symptoms, and most of them has responded either to the initial line of management with glucocorticoids or with your IVIG. In our center, whatever case we have, a few cases whatever we have managed, so we have managed with only your glucocorticoids and IVIG. Now coming to the transfusion practices in PICU. So we all know that low hemoglobin in children with critical care can lead to decrease oxygen delivery and thereby decrease oxygen consumption. So blood transfusion has its own safety concern, and efforts are needed to ensure appropriate RBC transfusion in decision making. So the Pediatric Critical Care Transfusion and Anemia Expertise Initiative, which is known as TAXI, has given these guidelines. Suppose if you have a critically ill child or a child at risk for critical illness, so if the child uh, has hemorrhagic shock where there is a huge volume of blood loss, then the child may need immediate transfusion, because the only way to treat this life threatening bleeding is to transfuse these children. Again, when the transfusion requirements are massive, ideally you should combine your red blood cell or your whole blood transfusion along with your plasma or platelets, either in the ratio of 2 is to 1 is to 1 or 1 is to 1 is to 1. Because if you give only red blood without giving plasma or platelet, it leads to hemodilution, and it may lead to a vicious cycle of more bleeding. Now, when you have a non-hemorrhagic shock, the guidelines states, so the trigger for transfusion is a hemoglobin of less than 5 gram per deciliter. And when the hemoglobin is 5 to 7, most of us will jump and transfuse. But again, you have to exercise your clinical judgment in managing these children and how severe are the symptoms. Depending on that, you can, if a child is with a hemoglobin of 5.5 or 6 and he's stable and is not requiring oxygen or minimal oxygen requirement, you can do away with transfusion, because we all know that transfusion has its own set of risks in critically ill children. We all know about TACO, that is transfusion associated cardiac overload, or TRALI, transfusion related acute lung injury. So you have to be judicious when you have stable children with low hemoglobin. And when you have a hemoglobin cutoff of above 7, if in a hemodynamically stable child, again, wait. If the child is not hemodynamically stable, again, use your clinical judgment. So usually in the management of shock, so during the acute phase, the target we normally target a hemoglobin of 10, and beyond that, once the child is hemodynamically stable, has come out of shock, the target should be more conservative. So again, like the transfusion criteria again depends on the underlying problem, like general critically ill, a child with post-operative problem, a child with respiratory failure other than your severe ARDS, sepsis and septic shock, non-life threatening bleeding, and child requiring renal replacement therapy. Ideally, they do good without transfusion. And when you have children with conditions like acute brain injury or oncologic diagnosis, or those undergoing hematopoietic stem cell transplant, there the cutoff should be a bit, you should be a bit more liberal with those type of children. So again, like the decision to transfuse RBC to maintain a hemoglobin of 7 to 9, depending on the cardiac reserve in children with cardiac diseases. So again, different conditions warrants different uh, decisions. So just to summarize, less than 5 transfuse, 5 to 7 depending on the hemodynamic and clinical status of the child, more than 7 wait if the child is not in shock. Now coming to the newer concepts in the management of diabetic ketoacidosis. So we have this PCAN fluid trial. PCAN is the Pediatric Emergency Care Applied Research Network, and fluid here stands for Fluid Treatment Under Investigation in DKA trial. So this trial is a landmark trial with regard to the fluid management in diabetic ketoacidosis. So there has been a raging controversy about fluid management in children with DKA. Generally speaking, like the North American guidelines are more liberal compared to the ones from the European societies. Now, the logic behind the restricted fluid regimen is, so if you give more fluid in children with DKA, they end up developing cerebral edema. That was the logic. So this PCAN and fluid trial enrolled more than 1,200 kids and randomly allocated these children to 4 groups in a 2 by 2 design, where you can see this protocol A1, A2, B1 and B2. So in this, half of the children received 0.9% saline and half of the children received 0.45% saline. And again, in these categories, in the normal saline and half normal saline categories, again, they were categorized to receive fluid at a fast rate and at a slow rate. So it has been found that the endpoint, what they have seen is the drop in GCS score during an hour during the first 48 hours of management. Now, so what they have found is the the risk of cerebral edema is independent of either the type or the rate of fluid administered in these children. Now, what was the usual teaching is the rapid osmotic changes with quick and liberal rehydration has been widely suspected to cause brain injury in DKA. However, this study gives credence to the more recent hypothesis, suggesting it's not the rate and the type of fluid which leads to cerebral edema, rather, it's the hypoperfusion and followed by reperfusion, as well as the neuronal inflammation, which leads to brain injury and thereby leading to cerebral edema. So, as most of the type of cerebral edema seen in these children are of vasogenic origin rather than cytotoxic. So this landmark study has proved that neither the rate of fluid nor the type of fluid has a bearing on the development of neurological complications. Rather, it's the hypoperfusion and reperfusion and the neuronal inflammation, which is the cause of which is the cause of mortality in children with DKA. Now, coming to the most important topic and often the most neglected one in PICU is the nutrition. Now, nutritional support therapy refers specifically to the provision of either enteral nutrition or parenteral nutrition in critically ill children. Now, the impact of nutritional status outcome in critically ill children is huge. So at the time of admission, all these children should have their anthropometric parameters recorded. So particularly your height, weight, length in case of children, the young lot, as well as the mid-arm circumference and the head circumference. Now we need to identify these children who are at risk, the extremes, either the undernourished and malnourished or the overnourished and obese children. So the recommended energy and protein intake. Now it has been seen most often that most of the children in the ICUs are kept NBM, either for unfound or unanticipated or unfound fears, or they have been kept for procedures like MRI. For doing an MRI, we keep NPO and we fail to get an appointment, and the child remains NPO for 6 hours and even at times more than that. So children who are borderline can acutely deteriorate, and in the long term it has been seen that they have a worse outcome with regard to length of hospital stay, the complications in the ICU, or mortality. So the recommended energy intake, so ideally we need to have measures to calculate the energy requirement, and most of us, we don't follow those theoretical things like your indirect calorimetry or so many formulas and equations. But you should try to and the guidelines which and the RDS, which are recommended daily allowances, they give the energy requirement for both macro and micronutrients for the healthy children. And these children's critically ill children's, they are different from the usual healthy ones. So with regard to protein, you should provide ideally 1.5 gram per kg per day of protein to these children, and at least you should provide up to 2/3 of the energy requirement in the first 7 days of ICU stay. What is the best route to commence and how early? So again, there are so many unfound fears that the child on stiff, the child is kept NPO for gastric residual volume. Now we normally don't start in sick children in the first 24 hours. So, but the guideline says you can start feeding in the first 24 to 48 hours. I start some trophic feeds because the small volume feeds helps in maintaining the gut integrity, and thereby it helps in preventing the translocation of the bacteria from the gut to the systemic circulation. So the best route is always the enteral route. And how early to commence? You can commence as early as within 24 to 48 hours. Your target should be to achieve one fourth of the requirement in the first 48 hours, and almost like two-thirds of the requirement by the end of the first week. Children who are on, even studies have seen that children who are on inotropes, not on stiff dose, but on moderate or mild to moderate doses of inotropes, can be given feeds. I mean, those small feeds which can help in maintaining the gut integrity. So always your target should be to start nutrition for these children at the earliest, unless and until there is clear-cut surgical contraindication. Every child in the PICU should not be deprived of this. This most important aspect. So, what are the benefits of enteral nutrition? As I said, enteral nutrition maintains gut integrity. It prevents translocation of the bacteria. The best site, now comparing the best site, like whether it should be gastric or the post pyloric feed, again it has been seen that hardly it makes any difference. So the best way to start is with gastric feeds, because post pyloric feed requires expertise. You need to put a catheter beyond the pylorus, and bolus feeding is not possible with your post pyloric feeding. Either you have to give continuous feeding. The best site would be the gastric, and the optimal method of advancing enteral nutrition, again, like as I said, aspirating and seeing the gastric residual volume, or it is more than 30% or 40% of the last feed, and you keep on moving. You take 2 step forward and 3 step backward. So it has been seen that unless and until there is a high risk of aspiration, even gastric residual volume has not found to have any logic to withhold the feeds. Now, the timing of parenteral nutrition, now there's a study which compared early parenteral nutrition with delayed, and it has been seen that children who have given early parenteral nutrition have fared badly compared to the delayed. So, if at all you are planning by planning to start parenteral nutrition, it has to be beyond the first week. There's no role for early parenteral nutrition, so as there is no role for this fancy nutrients, which what we call it as immunonutrient. It has found to have no benefit with regard to the management of children in critically ill children in PICU. Now, coming to the last but the most important topic, like the pediatric TBI. This is a very busy slide, but you can see that any child with traumatic brain injury, you need to maintain appropriate analgesia and sedation. So continue mechanical ventilation, maintain adequate arterial oxygenation. PaCO2 is again important. If high PaCO2, it can cause raised ICP. As we know that, so surges in ICP can lead to coning. So the target is to maintain a PCO2 in the range of 35 to 40, maintain normothermia, euglycemia, control, maintain intravascular volume, as hypovolemia, hypotension, hypoglycemia, all these are adverse factors with regard to the outcome of these children. So maintain an hemoglobin level. We have discussed this above 7. Treat coagulopathy if any. Keep the head end of the bed elevated to 30 degree, because that is the position. It has been found that the venous return would be optimal, so there won't be rise in ICP. Then with regard to the anticonvulsant, so both phenytoin or levetiracetam can be used, but from the Eclipse trial, we have seen that the safety profile of levetiracetam is better, but guidelines says either of these can be used. Consider continuous EEG monitoring throughout the management course. Again, nutrition as early as possible and treat hypoglycemia. Now you can see there are three pathways for management of these children. One is the ICP pathway, other is the CPP pathway, the third is the herniation pathway. Now, coming to the middle portion of this slide, the ICP pathway. If the ICP is high, you need to go for CSF drainage if you have an extraventricular device or a ventriculostomy. If you don't have, then use bolus of hypertonic saline. So hypertonic saline versus mannitol, again, both will achieve almost the same results. So hypertonic saline has to be infused in a dose of 3 to 5 ml per kg over 20 to 30 minutes. If needed, you have to use an analgesia and sedation, neuromuscular blockade, and when you do suctioning for these children, use lidocaine so as to decrease the stimulation and surges in ICP. If ICP still remains high after all these measures, like after CSF drainage, after bolus of hypertonic saline, following adequate sedation and analgesia and neuromuscular blockade, then you have to go for second tier therapies. What are the second tier therapies? The second tier therapies are the therapies to maintain your cerebral perfusion pressure. Your cerebral perfusion pressure depends on your ICP. So when you have, what is CPP? CPP is nothing but your mean arterial pressure minus your ICP. Because ICP is not controlled, ICP is high, your cerebral perfusion pressure decreases, which will lead to which will lead to cerebral hypoxia. Now carefully you have to manage, and when you have refractory surges, or when you have signs of coning like pupillary dilatation, hypertension, bradycardia, extensor posturing, then you have to do emergent treatment in the form of hyperventilation to try to reverse the pupillary dilatation. When your pupils are dilated and there is extensor posturing, it indicates it indicates tentorial or transtentorial herniation. There are different types of herniation with different clinical signs, which is difficult to discuss in this presentation. But when you have pupillary dilatation, like Cushing triad, hypertension, bradycardia, and extensor posturing, brief hyperventilation. Ideally, hyperventilation is to be tried when you have an intra ICP monitoring device in place. But your target should be to bring rapidly the PCO2 to 30 to 35 so as to decrease your ICP. Bolus of mannitol or hypertonic saline, and if all these measures are not yielding result, then go for craniectomy. So you have a DECRA trial which has stated that in these type of conditions where you have a refractory ICP, then your decompressive craniectomy helps. Now again, the most important is maintain the CPP, that cerebral perfusion pressure appropriate for age. So minimum should be 40. So confirm appropriate intravascular volume status either by your 2D echo or by your by central venous pressure. Start vasopressor. The ideal vasopressor to be used in these scenarios is noradrenaline, and also give a bolus of hypertonic saline. Now, centers which can monitor brain tissue oxygen, so they should target a brain tissue oxygen of more than 10, and if anything which leads to a fall, then you increase your FiO2 so as to maintain, or you adjust your vasopressors and optimize your hemoglobin. Now coming to the second tier therapies, so increased ICP which is resistant to the first tier therapies or which is refractory. Repeat CT scan if surgical option is being considered. If you notice a new or an expanding surgical lesion, then surgery as indicated. Now, if you have then you need to consider for additional advanced neuromonitoring, like your EEG, your transcranial Doppler. But the role of transcranial Doppler in children is again debated. Then the other modalities which can be utilized in these type of scenarios is your barbiturate infusion, maintaining moderate therapeutic hypothermia, hyperventilation, as I said, targeting ApCO2 in the range of 30 to 35, and you can optimize your osmolar therapy. Now, summarizing my presentation, prefer balance salt solutions. We have seen the trend, and we may be using this in the future instead of your usual time tried and tested normal saline. Restrictive fluid strategy in sepsis. Again, it has been seen that in resource limited settings, it's not the shock which kills, but it's the overzealous fluid which is administered without proper monitoring. Transfusion strategies, as we are all aware of the need to optimize our transfusion targets. Again, the trend is towards conservative numbers. DK, we have seen from the PCAN and the fluid trial that the role of fluid boluses and the type of fluid has no bearing on the development of neurocomplications. And the importance of early enteral nutrition can't be overemphasized. And last but not the least, the most important is the management of the CNS emergencies, and most commonly in pediatric critical, the pediatric TBI, where sequential tired management can be adopted so as to control refractory rise in intracranial pressure. Thank you. I would be more than happy to take up questions if you have any. Please feel free to post your questions.
Yeah. Thank you, Dr. Khalil, for the excellent presentation. It was very informative and well presented. I can see a few questions for you. So, Dr. Kasam Kumar has asked one question. What is the ideal regime of insulin for DKA below 2 years of age?
So when you talk about insulin in DKA, we always advise to go with regular insulin in form of infusion. So the dose normally advises like no, either you can go with 0.1 unit per kg or per hour, or with hello. Yeah, in the management of DKA, so after fluid resuscitation, once you have adequately resuscitated the child, and when you are sure that your potassium levels are not low, then you can start on insulin, your regular insulin infusion. You can start either in a dose of 0.1 unit per kg or 0.05 unit per kg per hour. So
Uh,
again, monitoring of the most important aspect in the management of these children is again monitoring, hourly glucose monitoring, then monitoring of your potassium levels. As the moment you start insulin therapy, your potassium levels can drop. So it moves from intravascular to intracellular compartment, thereby may lead to life-threatening hypokalemia. So you have to ensure that you have adequately resuscitated and you have your potassiums are in the normal range.
yeah, another question is from Dr. Shanmuga. Sir, is there any role of steroids in treatment of raised ICP?
Role of, pardon, I didn't get.
Is there any role of steroids?
Steroids.
Yeah, in treatment of raised ICP.
Yeah. So as such, if you see the Brain Trauma Foundation guidelines, steroids has got no role in the management of these children. So because most of these children, you have acute rise in ICP, usually steroid for any problem, they take time to act. Steroids doesn't act immediately, and they, because most of the actions of steroids are in the are at the nuclear level. They get translocated to the nuclear level nucleus, and they thereby activates the genes which helps in transcription and translation, and all this takes time. So most of these emergencies where you leave aside your traumatic brain injury, steroid takes time to act, and as such in traumatic brain injury there's no role of steroids. Hello. Hello.
Yes, sir. Yes, sir. You are audible, sir.
Yeah.
So others are a compliment for your presentation. Like Dr. Kasam Kumar has mentioned good presentation, sir. Dr. Pradeep Rathore, nice presentation, sir. Dr. Lala Tendu Kumar, excellent talk. Yeah.
Yeah.
Yes, and Dr. Reena Matthew, very informative presentation, sir. Similarly, Dr. Srinivas has also complimented for this excellent presentation. So all are I can see the compliments.
Thank you. Thank you so much. So I would like to thank my colleague, Dr. Reena, who has helped me with this presentation. So thanks a lot, Reena. She has helped me a lot in formatting these slides.
So further, if any participant has any question, I request you to unmute yourself and you can discuss in this forum. One question came from Dr. Srinivas. Why do you need to delay for 1 week parental nutrition?
Yeah. So as I said, sir, like most of the fear which we have when we think of nutrition in children are unfounded and are not backed by robust studies. So most of the children which we deemed inappropriate to start on enteral feed. So in fact, they do tolerate enteral feeds very well. In fact, the study which has been done, which compared early versus late parental nutrition. Early means starting within the first 48 hours, and late means beyond 1 week. It has been seen that the mortality is high in early. Why? Because to start all this parenteral nutrition, you need to have your intravascular catheters. Maybe that is one reason where these children will have a lot of complications with infection. And the parenteral nutrition with the lipid emulsions, they have again a high risk of infection. So by common sense, like the ideal and the most easiest way is to go by what we can do it in a normal kid, like go by enteral feeds. So parenteral, you need lines, you need things from outside which needs to be prepared. There can be lapses during preparation if you don't have a laminar flow. All this can add to the risk, and no, that may be the reason why children who have been on early parenteral nutrition have not fared well. In fact, the mortality has been found to be way high when you compare to children who were started on late parenteral nutrition.
So we got one more question from Dr. Pradeep Rathore. Sir, hourly checking GRBS will cause pain and sleep disturbance. Can we monitor third hourly or is should definitely monitor every hourly?
See, basically in the acute phase, in the first 6 hours, so where you can expect once you start your fluid therapy, what will happen? Your renal perfusion, everything improves, and your blood sugar drops. So at least in the initial few hours, to say first 6 hours, the monitoring has to be meticulous. In fact, decay is a condition where where there is a lot of emphasis on monitoring. No, the monitoring has to be meticulous. So once the kid settles, and once there is a constant trend constant trend of blood glucose, then you can space your testing to a less intensive regimen. Like you can monitor, as you said, third hourly, fourth hourly. But in the acute phase, in the first 24 hours, the monitoring has to be spot on, and more so in the first 6 hours.
Yeah. So any further question? I request all delegate, you can ask, you can unmute yourself. You can discuss anything in particular. So Dr. Satyajit has also complimented for this very good presentation, and it's
Thank you, Satyajit.
yeah,
Satyajit is my dear buddy.
yeah.
Okay, Pooja, I think let's end here.
Yes, sir. So, on behalf of Ankura Hospital for Women and Children, we thank you all the participants who attended this session today by taking out your valuable time. Thank you, Khalil sir, for being our speaker for the day. So, thank you everyone once again.